All right. Well, welcome to another episode of The Monk and the Hedonist. Today we have a very special guest, Dr. Robert Lustig, who is a professor emeritus of pediatrics in the Division of Endocrinology at UCSF. He specializes in the field of neuroendocrinology with an emphasis on the regulation of energy balance by the central nervous system, which he will explain and break that down for us a little bit more. Dr. Lustig has become a world-renowned expert on childhood obesity and diabetes. He has written multiple books and papers. His most recent book, termed Metabolical, it focuses on the discussion of metabolic health and nutrition and exposes some of the leading myths that underlie the current pandemic of diet-related diseases. Dr. Lustig, welcome. We are very excited to be able to speak to you today.
Thank you, Deepti and Bobby. My pleasure to be here.
All right. And Bobby, what are we drinking today? I have some Topo Chico. I'm keeping it simple.
Deepti, I'm actually being healthy today as well. I'm drinking some black cherry sparkling water.
That'll work. And I've got some Pellegrino, it's kind of the standby.
Yeah, that's true.
We're all on the monk side today. We're keeping it simple. I was afraid to bring something that may have had hidden fructose. All right. So, Dr. Lustig, tell us a little bit more about how your early career led to your current interest.
Yeah, people ask me all the time, how'd you get into this? And the answer is totally through the back door. I had no agenda. I went into pediatric endocrinology to take care of short kids. And then the short kids got fat on me. And, it was my responsibility to take care of them. And, I had learned nutrition in college. I had majored in nutritional biochemistry at MIT. So I was always interested in it to some extent. But, I was more interested in sort of the vitamin deficiency kind of thing, the vitamin B1 and the, vitamin D story. But, I could not ignore what was happening around me. But I didn't know any better. And in medical school, I certainly didn't learn any nutrition, which was funny because one of the leading lights of, nutrition in the 1970s, Maurice Shields was at Memorial Hospital, was one of my professors, but, they never even trotted him out, to give a lecture. And so basically I sailed through medical school without any nutritional background or education, which, as it turns out, is pretty normal because only 28% of medical schools even have a nutrition curriculum. And those that do, you get a total of 19.6 contact hours for an entire, medical school training over 4 years. It's pretty paltry when you think that, diet-related disease is 75% of all medical pathology. So I didn't know any better. And, anytime I would bring up anything having to related to nutrition, the doctors, the professors would say, oh, we don't do that. That's not how we take care. Basically what you learn in medical school is prescription pads and procedures. And so that's how I practiced too, until it didn't work anymore. And I started doing research in obesity when I moved to St. Jude Children's Research Hospital in 1995 in Memphis, Tennessee. I had a cadre of about 40 kids who had survived their brain tumor only to become massively obese because of either the surgery or the radiation or the tumor itself. This form of obesity we in medicine, know because it's been around and it's been known since 1901. Debunking and Freilich both described it. It's called hypothalamic obesity because of hypothalamic damage, and it was the very first, syndrome of obesity that we knew wasn't inherent. And I had to take care of these kids. So I did my research. And, in 1994, the year before I moved to St. Jude, the hormone leptin had been discovered. And leptin, for those in your audience who don't know what it is, it's a hormone that's made in your fat cells, travels via the bloodstream to the brain, and tells your brain, hey, I have enough energy on board to burn properly and to not be hungry because I'm topped off. Okay? It's like the servo mechanism on your weight, in the same way your thermostat in your house is the servo mechanism on your heat. All right? Point was, these kids were not responding to the servo mechanism because, the thermostat was dead because of the tumor. And I had to take care of them. And all these kids did was gain weight. In 1975, George Bray, one of the fathers of obesity research in America, he had admitted 8 of these kids to his clinical research center at Harbor UCLA Medical Center. And he locked the door and threw away the key and fed them for a month 500 calories a day. 500 calories a day for obese kids. So what do you think their weight did over the month?
I guess.
I hope it dropped.
It went up. It went up.
Okay.
So how do you gain weight on 500 calories a day? Are you basically, are you metabolizing air? Well, it turns out these kids would rather store it than burn it. And the reason was because they couldn't see their leptin. Because their brain registered leptin deficiency, even though they had plenty of leptin. They just couldn't see it. They had what we would call anatomic leptin resistance. They could not see the leptin signal. And therefore, their brain thought they were starving. And therefore, they ratcheted up their food intake in terms of appetite, and they ratcheted down their energy expenditure in terms of activity. So these were kids who sat on the couch and ate Doritos and slept. And they had lost all interest in the world around them because they couldn't generate a sympathetic response. They couldn't generate a fight or flight because their brain thought they were starving, because that's how you conserve energy, because the sympathetic nervous system makes your muscles twitch to burn energy. So I had to take care of these 40 kids. So, like I said, leptin had just been discovered, and I knew that I couldn't fix the leptin servo mechanism. So then the question was, well, what's downstream of that? And we knew from rat studies starting in the 1920s and all the way through the 70s, that if you lesion the hypothalamus, the rat becomes massively obese. And the reason is because they generate a lot of insulin. There's a connection between the hypothalamus and the pancreas that goes haywire because they're trying to store more energy. So I said, well, okay, maybe these kids are releasing enormous amounts of insulin, and we knew that already from other research. Maybe I could give these kids a medicine that would block insulin release. And we had a medicine at our disposal called octreotide, which is normally used for growth hormone secreting tumors, but it also blocks insulin. So I said, let's give these very unfortunate, kids octreotide and see what happens. And we did it in a formal, pilot study. And lo and behold, 8 kids all started losing weight. But something even more remarkable happened. They started exercising spontaneously. These were kids who sat on, lumps on a log. The parents would complain, my kid is not interested in anything. I can't motivate my kid to do anything. And that one kid became a competitive swimmer. 2 kids started lifting weights at home. One kid became the manager of his high school basketball team, running around collecting all the basketballs. I mean, these kids had 0 interest in anything. And now, all of a sudden, they've woken up. Now, the parents would say, I've got my kid back. And the kid would say, this is the first time my head hasn't been in the clouds since the tumor. I mean, this is really remarkable. We ended up doing a double-blind placebo-controlled trial. And the same thing fell out. And this time we built a quality of life questionnaire in that showed that the change in their quality of life correlated with how well we suppressed their insulin. So if we got the insulin down, these kids not only lost weight, but felt better. And then we did this in adults without brain tumors. And the same thing happened. And what that told us was that the gluttony and the sloth that we associate with obesity, the increased intake and the decreased expenditure, was actually not the cause of their obesity, but rather a result of the biochemical dysfunction, a result of the leptin resistance, and that insulin was the blocker of leptin. Insulin blocks leptin. And that's why these kids couldn't see their leptin signal, because their insulin levels are so high. And when we got the insulin down, now they could, and they felt better. So I changed my entire clinic at UCSF from an obesity clinic to an insulin reduction clinic based on this.
Quick question, Rob. When those kids were only getting 500 calories, in some ways they were almost kind of intermittent fasting, or there was this, calorie restriction. Why wasn't there insulin levels dropping from that?
Well, these kids have, basically even the 500 calories would cause massive increases in insulin. So a normal insulin response for you and me to a glucose tolerance test would be like a peak insulin of about 100. These kids went up to 1,000, 1,500. So they're putting out insulin hand over fist. They don't have an intermittent fast.
Makes sense.
And that's because of this leptin dysregulation that was going on.
Correct.
Yeah. Well, that's very rewarding work, actually, to have done at a time when, most people weren't thinking that way. And the way we viewed obesity was very parochial in a sense, if you will. And even nowadays, I still feel like that divide is still there. There's probably 25% of the medical community that really understands how to truly get this under control. And it's so multifactorial, as you're pointing out. It's not necessarily calories in equals calories out.
Well,
based on your example.
I'm right now writing with a colleague the history of obesity research in America for the Pediatric Endocrine Society's 50th anniversary. And what I can say is, that there have been these two schools. There's the school of energy storage, and there's the school of energy balance. And they are not the same. The school of energy storage actually started earlier. It started with Freilich and Babinski, in 1901 because of kids like this, right? And then we learned about Cushing syndrome back in the 20s with Harvey Cushing. And so there was a, great interest amongst endocrinologists in the concept that obesity was due to a defect in energy storage, that there were hormones that drove weight gain. That's the energy storage school. But then something happened. World War II happened. All right? And what happened after World War II was that the psychiatrists got involved. And they saw obesity as a matter of energy balance, matter of calories. And to be honest with you, this was pushed by the food industry, very specifically. And we have the data, we have the papers to show how this was done. And so they sort of took over, endocrinology had sort of moved on, onto other things at that point, and obesity was much less interesting. And, because we didn't have the hormone, we didn't have leptin yet. And so it sort of sat on the back burner while basically psychiatry took over this notion that this was really a defect in energy intake, i.e. gluttony, and decreased expenditure, i.e. sloth. And so these two competing schools, were duking it out throughout the, mid to late 80s. And then finally in 94, leptin came about, and that kind of explained the difference. The problem is it's sort of been baked into the cake at this point. pun intended, that, people, the whole country, the whole world, thinks that this is a matter of calories, and it's just not. And the more data that we, generate, and the more research we do, the more we're very sure that this, concept of energy balance is just that. This is the problem. We have to kill the calorie. And that's one of the reasons I'm happy to be talking about this with you today, is because that's my job. That is my unwritten job, is to kill the calorie.
So if we take all of this a step back, can you just start with talking about how you define healthy? Like, what does that mean to you?
Well, I know what it means to me, because I wrote about it in my book, Metabolical. I have a whole chapter on what does it mean. I will tell you that the FDA says that healthy means low cholesterol, normal sodium, and a normal level of potassium. And it's like, what? That's healthy? Are you kidding me? And no vitamin D deficiency. So that's their definition of healthy. I mean, it's just nuts. The USDA doesn't even have a definition, because if they did have a definition, then all of the food in America would have to be declared unhealthy, because no food could actually meet it. So they don't even bother. So everybody and his brother has a different definition of healthy. And in Metabolical, I define healthy based on the, decades and decades of research as to what's going on with the new information that we have learned, both about the hyperinsulinemia, based on the microbiome, based on what's going on in the brain. Okay. And I, posit that there are six words that define healthy. 2 clauses, 6 words. Protect the liver, feed the gut. Any food that does both is healthy. Any food that does neither is poison. And any food that does one or the other but not both is somewhere in the middle. And believe it or not, the empiric data on virtually all the foods that there are fit that paradigm. So I'm very happy to debate that and discuss that and argue it. But that's my definition of healthy. And, I'd love to hear yours.
So quickly on the protect the liver, feed the gut, if you were to tell our listeners, what should they think about when they think about protect the liver?
Right.
And what should they think about when they think about feed the gut? Like, if that's something that, if anyone takes away anything from this, that could be very useful.
Sure.
When people are making choices in their daily life.
Sure. So the thing that people need to understand is, what does the liver do? What's it for? Why do you have one? Why do you die if you don't have one? All right. So the liver is your primary detoxification organ. It has all the enzymes necessary to detoxify poisons. Now, some poisons are in low dose. Some poisons are in high dose. Some poisons are extraordinarily potent, some less potent. Okay. Some will kill you with 1 dose at parts per billion. Other will kill you in, long term at parts per thousand. So we have acute toxins like sarin and ricin and VX gas and cyanide. 1 exposure, 10 seconds, you're dead. We also have chronic toxins like carbon tetrachloride, benzene, alcohol, tobacco smoke, where arsenic, where 1 exposure won't kill you, but 10,000 exposures very well likely will, like tobacco smoke or alcohol. So, different toxins, different capacities, different effects, but they're still toxins, acute or chronic. What I argue in my books and, in my papers is that sugar, and specifically the molecule fructose, the sweet molecule in sugar, has no biochemical reaction in the body. It is completely non-essential for all vertebrate life. There's nothing it does other than provide energy. And it doesn't even do that because it actually is a mitochondrial toxin. It inhibits 3 enzymes in the mitochondria. And the mitochondria are in charge of burning energy and generating ATP, which is, of course, the chemical power of the cell. Well, if you have a mitochondria that doesn't work very well, you have a cell that doesn't work very well. And you have a human being that doesn't work very well. And in fact, I would posit to you that all of the chronic diseases that are going haywire in our society, and I'll name them for you: type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, cancer, dementia, fatty liver disease, polycystic ovarian disease, these 8 diseases, which currently account for 75% of the entire healthcare budget of the United States. And none of them have a reversal or cure. The reason is because each of these is really a mitochondrial disease. These are the diseases of defective mitochondria in different organs. And there's no medicine that reaches the mitochondria. Therefore, these diseases are not druggable. But what does reach the mitochondria? Food. Well, it can reach the mitochondria to do good, like glucose, or it can reach the mitochondria to do bad, like fructose, and others, not the only one, but the main one. And so what I would argue is that we are poisoning ourselves on a meal-to-meal basis with a chronic, dose-dependent mitochondrial toxin. And that's why we have this pandemic of chronic metabolic disease.
Yeah, that's a great way to break it down, actually, for someone to really understand, because I think this understanding of glucose and insulin in the body it comes too late in our life. And this is something that we can really take control over very early, even from the time kids are growing up. I think, the food industry still has a big hold on how children eat. And also our nutritional IQ is pretty poor in this country in general. By virtue of the food that's available. And so if parents don't know what they're feeding their children, that also becomes this never-ending cycle. And I think the earlier you can break it and train your brain and your taste buds, the better.
Indeed, I couldn't agree more. I mean, to be honest with you, the only thing anybody knows about nutrition is what the food industry told them. And that's the problem. And
even physicians. I mean, that's exactly a lot of physicians' knowledge. Yeah, which is always mind-boggling to me, actually, because we know that disease is so rooted in our lifestyle, especially the most common diseases that we're sitting, in the hospital treating.
Well,
so
that's true, but virtually all physicians, I won't say all, because that's, never say never, and don't overblow it. But, virtually, the overwhelming majority of physicians think the problem is calories. They think the problem is obesity. They think obesity is the cause of all of these diseases. And I know that that is not true. I know that is not true. In fact, we have 3 review articles coming out on April 5th in the journal Biochemical Pharmacology. Okay. And these are long review articles. Okay. With 43 authors worldwide. All right. And 408 references in the first article, 740 references in the second article, 226 references in the third article. And what they say in a nutshell is that obesity and metabolic disease are not the same thing. They are 2 different things. Now, they do travel together. I don't argue that. For sure, most people who are obese have a chronic metabolic disease, 80%. But it turns out 40% of normal weight people have the same chronic metabolic diseases. And I can prove to you using 2 medical paradigms that obesity and metabolic disease are different. They are different kettles of fish. They are not automatically related. And here they are, the two paradigms. One is called the Little Women of Loja. This is first written up in the 1990s in the New England Journal of Medicine. It's a founder effect mutation in Ecuador of the growth hormone receptor. It's the Lerone dwarf cohort in Ecuador. And these, mostly women, there are some men too, but mostly women, are massively obese. And they get no diabetes and no heart disease. And they actually outlive their SIBs. They outlive their SIBs, even though they're massively obese. They
didn't have cancer either.
Sorry?
They didn't have cancer either.
No cancer, no heart disease. All right? And despite being massively obese, okay? And no diabetes. On the other hand, conversely, we also have a disorder called lipodystrophy. These people don't have too much fat, they have too little fat. They have so little fat, they have no place to put energy, except in their liver and their muscle. So they end up with ectopic fat, even though they're not obese, even though they're thin. And they have insulin levels in the thousands, and their glucose levels in the hundreds. They have the worst type 2 diabetes because you can't even treat them with insulin because there's no place to put the sugar because there's no fat. All right. So these people are thin and they're sick as hell, whereas the Little Women of Loja are fat and healthier than you. All right. And the reason is because subcutaneous fat or big butt fat, or, does this bathing suit make me look that fat? Politically incorrect, but whatever. Podcast. Is actually, believe it or not, protective. It's protective. It's our body's attempt at trying to put the energy someplace where it won't do any harm. It's the other fat, the visceral fat, which is cortisol driven, and the liver fat, which is sugar driven, that actually causes the disease. And so understanding these different fat depots and understanding their contribution to chronic metabolic disease is the reason we wrote these articles. And then once you understand that, you understand this concept of obesogens, chemicals in the environment that actually promote insulin resistance, promote adipose tissue differentiation, promote visceral adipose tissue deposition, promote these chronic metabolic diseases that have nothing to do with what you eat, because they're affecting the same receptors. So we're very excited about this, and we hope that this will have get some traction and help people understand that we've gotten the whole obesity, metabolic disease, diabetes, cancer, connection completely wrong for the last 50 years. And to be honest with you, the reason is because it was a put-up job by the food industry. So they could sneak sugar into our food because they learned that when they add sugar, you buy more.
It's fascinating how far we've come along in medicine, and yet how little we still know about how the human body is operating. I mean, just think about how many things have changed even in your time in medicine,
Yeah.
Right?
Well, I've been around long enough to see the cycling.
Right. Can you comment on the food industry and some of the biggest myths that are surrounding it for people that, they don't even think about on a regular basis?
Well, the big one is a calorie is a calorie. That is just, it's total complete BS. All right. The food industry will tell you a calorie is a calorie, a sugar is a sugar. Okay. And the reason they say that is because that's the way they avoid culpability. Because if it were true, if a calorie were a calorie, if that were true, then the problem of obesity would be a problem of energy balance, right? There's that energy balance again, which would basically say it's calories in and calories out. Therefore, it's about two behaviors, gluttony and sloth, which presumably you're in control of. but you're not. And, if that were true, then if you're fat, it's your fault. So there goes the, assignment of culpability. Therefore, any food can be part of a balanced diet. So that allows them to basically put anything they want in anything. Okay. And then they get to say, don't pick on our calories, go pick on somebody else's calories. So all of that comes from this notion that calories are fungible, that any one calorie is like any other calorie. Right? And that is just not true. The reason is because we are not bomb calorimeters. A bomb calorimeter is a contraption where you throw the food in and you blow it up, you explode it, and it gives off a certain level of heat. Okay, and that heat then can melt water. And that's the definition of a calorie. And Wilbur Atwater, who, was the guy who figured out that fat had 9 calories per gram and protein and carbohydrate had 4 calories per gram. Okay, he's the one who basically started us on the wrong path. And the dietitians, they picked up on this. And they said, oh, calories? We can do math. This isn't math. This is science. Okay, and the reason is because 1 calorie is not like another calorie. So fructose and glucose are not the same for all the reasons I just told you, because fructose is a mitochondrial toxin and glucose is not. Protein, turns out that when you burn amino acids for energy, you actually have to invest more energy to take the amino group off the amino acid in order to turn it into an organic acid than the energy you have to commit to phosphorylating a carbohydrate. So there's a net deficit in comparison. Even though they liberate 4 calories per gram, you have to invest energy to get it to that point. So there's a difference between the two. So a calorie is not a calorie. And then, of course, with fats, there's omega-3s, which are heart healthy, anti-inflammatory, save your life, precursor of EPA and DHA, which are necessary to prevent Alzheimer's and depression. And over here, we got trans fats, which are the devil incarnate, which basically poison your mitochondria also. They're consumable poison. They're both 9 calories per gram. One will save your life, one will kill you. Okay, because a calorie is not a calorie. Right? Bottom line is, until we put the final stake through the heart of this myth, okay, nothing will change. And I am hoping that these 3 review articles that come out on April 5th will be that final stake in the heart. So that's
what do you think about all of these, diet or lifestyle companies like Optavia, Weight Watchers? There's so many people that swear by them that help them lose weight and change their life. What do you think about that?
Show me the data. Ends of one are not science. Oh, there's no doubt that some people will lose weight on Weight Watchers. I don't argue that. And there's, plenty of other companies, where they will, have testimonials from this patient or that patient. And I don't even argue that. The question is, what does it do for the, overwhelming majority? And are there predictors? Are there things you can measure a priori, up front, before somebody embarks on any one of these, weight loss protocols that will tell you whether or not they will respond or not? And we're working on that. I mean, we actually have a skeleton flowchart for that, for personalized nutrition and personalized weight loss. And it actually works. And to be honest with you, that's what I did at UCSF. That's what our pediatric obesity program did. We figured out what's the reason for the high insulin and attacked that. So every kid did not get the same therapy. We personalized our therapy to get the insulin down. And when we got the insulin down, those patients lost weight and kept it off. We had a much higher success rate than any of our colleagues and competitors at other medical schools or hospitals, because we were treating the specific pathology. These companies, they might treat one patient, but then they're going to be 8 more or 9 more that won't be treated. And, then, they'll throw up their hands and say, non-compliance, or, oh, it doesn't work for me. Yeah, that's right. It doesn't work for them because it wasn't meant to.
Yeah. And you bring up a great point. So if the patient showed up to you what kind of workup would you do? What kind of labs would you do, or any scans to get a baseline of their metabolic health?
Right. All right. So what's the skeleton of workup? So of course, history is most important. Absolutely the most important. And the thing that we focused on that almost nobody else did was what happened in utero. What happened before the baby was even born, before the patient was even born. Now, the good news is, as a pediatrician, I could usually get that information from the parent, because the parent brought the kid, because I'm a pediatrician. Right? Most adults don't know their birth history, but they need to. They ought to. And if your parents are still alive, find out, because it's going to be important. Because we learned that obesity and really aging starts in the womb. So,
but what kinds of things do people need to know as adults? Because this might be important for some of our listeners.
So the big thing is whether you're small for gestational age or large for gestational age. That's the big thing. That's the thing that you can probably know just from birth weight. That'll tell you a lot. There are other things that you can know also in terms of exposures or in terms of family stress that we now know, translate into changes in placental cortisol, glucocorticoid transport, et cetera. Mother's sugar consumption during pregnancy is extraordinarily important. We always thought that what mother consumed didn't reach the fetus. Garbage. Oh, yes, it does. We always said, fructose doesn't cross the placenta because the placenta does not have the GLUT5 transporter, which is the one that's specific for fructose. That's true. It doesn't. It has the GLUT7, 9, and 11 transporters, which do even a better job. It's just that it's not specific for fructose. They transport glucose too. So in fact, the baby is bathed in the fructose that the mother consumed. And we now know, because fructose is a mitochondrial toxin, that is affecting the rate of cellular growth versus burning in the fetus before the fetus is even born. And we actually have the data from animal studies to absolutely document this. And the correlative data on humans is really there also. We just can't prove cause and effect there, but the association is very robust. One of the biggest signs of problem in utero is when the baby comes out, malocclusion. And you can know malocclusion by age 1. It turns out malocclusion is in part due to changes in mandible or maxilla growth prior to birth, which are the maxilla grows by cancellous growth, having to do with pressure on the incisive suture pushing from underneath. The mandible growth has to do with IGF-1, which is oxygen dependent. So and ATP dependent, in terms of whether those mitochondria are working or not. So you might end up with malocclusion as a phenomenon that tells you that things were actually a problem in utero. And everyone's got malocclusion. That's why everyone needs braces today. They didn't used to. That's an example. Okay. And it turns out that if you have malocclusion, you're going to have obstructive sleep apnea as an adult. And if you have obstructive sleep apnea, you got metabolic syndrome and you're going to die from it.
And how many people have undiagnosed obstructive sleep apnea?
About,
as an anesthesiologist, there's
you tell me.
Plenty. There's so many, and it's so disturbing that people don't know about that.
Right. So there's a lot to be
What
known.
else? Yeah.
There's a lot you can find out. There's a lot you could interpret if you knew what was going on. So, we gathered all those data for our patients, and that's why we were able to determine what the problems were. The other thing that we, did was we drew lab tests. We drew fasting lab tests at baseline, the first time we saw the patient. And the things we would look at are fasting insulin and fasting glucose, but the glucose is like the last thing to change. Horse is already out of the barn if that's high. Okay, the fasting insulin is probably the single most important test to assess chronic metabolic disease. And the American Diabetes Association says don't draw it. So why does the ADA say don't draw it? And I say it's the most important test. What's that schism about? Well, the ADA says don't draw it for two reasons, and they're both specious. They're both garbage. Here's what they say. Well, fasting insulin assays are not standardized across the country. That's true. And it is a problem. I'm not saying it's not. Who cares? If it's high, that's what matters. One of the reasons that fasting insulin is not standardized is because the cheap assays pick up proinsulin as well as insulin. Proinsulin is the precursor molecule. So proinsulin is cleaved by prohormone convertase 1 to C-peptide and mature insulin. And so, the assay can pick up both. And so it's complicated to interpret, especially when you have a lot of proinsulin around. So that's true. I don't argue that. But if it's high, it doesn't matter. It means you got a problem. The second reason that the ADA says don't draw it is that fasting insulin levels do not correlate with obesity. That's true. It correlates with metabolic health. And as I've told you, metabolic health and obesity are two different things. So they've got it wrong on both scores. So I'm doing my best to actually, make the ADA, wake up and smell the coffee. They got to get woke, but they ain't yet.
I'm so glad you addressed that, because I think it's very hard for people to understand why fasting insulin is so important. And the majority of general practitioners are not checking this test. And in fact, a majority of them are rejecting it when I'll tell my colleagues or, friends, peers to ask to get their fasting insulin checked, because everyone's at a stage where it's reversible at this stage. And there's a lot of pushback.
Well, you're always going to get pushback for something they don't understand.
Right.
So this is why I wrote the book. This is why, how do you educate a physician after they've graduated medical school? This is a hard question.
It's true, but we all are subjected to continuing medical education. And I think this is a really big component of doing that. And I think it's really important, because this is what actually will save lives on a chronic level, is if we can get to the root of metabolic disease faster, sooner.
More. Here in California, when I was, still in practice, I had to take 12 hours of palliative care to keep my license. Okay. Why can't they demand that physicians take 12 hours of metabolic health / nutrition, really just metabolic health, to keep their license so they can learn this stuff? We're actually, I'm trying to, make that case.
And just, can you reiterate one more time why you think fasting insulin is one of the most important lab markers that someone can get to give them data on their metabolic health?
Well, it tells you whether or not you've got mitochondria that work or not. Because if you have mitochondria that work, you don't need much insulin. You only need insulin for mitochondria that don't work.
And what do you advise people to be at normally?
For fasting insulin? Well, less than 15 for sure. The lower, the better. 2 is good. Up to 7 is fine. Once you get above 7, it's probably all right. But once you get above 15, you got a problem. You got a big problem. So that's sort of a number one on the list. There are 2 other tests that people, get routinely, that if they knew how to interpret them, they could actually use them to help their patients. One of them is an ALT, alanine aminotransferase, which comes in a standard lab panel, right? And the problem with, so ALT tells you how much liver fat there is. It's sensitive, but not specific. So there are other things that will raise your ALT. I understand that. But if it's high, there's a good chance there's liver fat. Right? Now, the question is, what's high? Now, when I entered medical school back in 1976, the upper limit for ALT was 25. Today, it's 40. Same test. How come? What happened? Answer, everyone has fatty liver disease. 45% of the population has fatty liver disease, and they don't know it. So when they go in and get their blood drawn, they think they're healthy, the lab doesn't know. They just conglomerate, 10,000 lab tests and draw a normal distribution. And they go, 2 standard deviations over here, that's the cutoff. Oh, it's 40. Okay, so on the lab slip, it says, ALT less than 40. Garbage. It's 25. If you use 25, then you'd know that anybody who has an ALT of 30 is already question mark. In addition, we've learned that African Americans, for whatever reason, and we're still trying to figure out why, they run an ALT that's about 5 points lower. So they get into trouble with an ALT at 20 or greater. And so you need to know that too. So there's all sorts of nuances that if you understood, you could actually use the data to interpret, much more correctly. So that's number 2. Number 3, uric acid. Now, my 2 colleagues, Rick Johnson just wrote this book called Nature Wants Us to Be Fat. And here it is right here. That's it right there. See it? Okay. And my other colleague, David Perlmutter in Naples, Florida, wrote this book called Drop Acid. Oh, there it is, by the way. They didn't pay me for this.
Yeah. Next on my book list to read.
The point is that uric acid is a bad guy in the story. And the reason is because uric acid is, number 1, a marker for both purine and also sugar excess in the diet. And uric acid is the endogenous inhibitor of endothelial nitric oxide synthase. So it's a major contributor to blood pressure. And lastly, uric acid is an inhibitor of carnitine palmitoyl transferase 1, which is the enzyme that regenerates carnitine. And carnitine is necessary to shuttle fatty acids into and out of the mitochondria for beta oxidation. So when your uric acid is high, that means your mitochondria are not working. And what makes your uric acid high? Sugar. So they know that, and they wrote about that. And so we use uric acid as a marker of mitochondrial dysfunction and sugar consumption, both, proxy. And the question is, what's a normal uric acid? The lab slip says 7. Garbage, 5.5. So if you use the data that's provided to you and you understand how to use it, you can actually figure out a whole lot of stuff. And the goal is to get doctors to understand what they're doing. Because right now, I'm kind of ticked off.
You and me both. Okay, so fasting insulin, uric acid, and ALT sound like the 3 must-haves, good starts.
Lipid profile also. And remember that, your serum triglyceride is your VLDL, and your VLDL comes from your liver. And that LDL is 2 LDLs, not 1. There's large buoyant and small dense. Large buoyant is cardiovascularly neutral, but that's the one that statins lower. Who cares? Because it's cardiovascularly neutral. Small dense is the bad guy, and that's the one that carbohydrate and sugar drive. Okay, and statins don't do a damn thing for those. So everybody who says, oh, your LDL's high, go on a statin. Garbage. Turns out the increase in longevity from being on a statin for primary prevention is 4 days. And you run the risk of type 2 diabetes because statins are a mitochondrial toxin.
Right, which a lot of people don't think about. And we're, a lot of the medications that we put patients on chronically, PPI, statins, and never bother to change them around. NSAIDs, they do more damage than actually good for patients.
So that's sort of the basic armamentarium that physicians can walk in with and know something right off the bat.
Let me ask you one thing, because I know we're going to run out of time here because there's so many interesting things to talk about. What is your opinion on relatively healthy person, which I think that's actually probably hard to find once you start digging deeper into people's metabolic profiles and biomarkers. But what is your opinion on wearing a continuous glucose monitor for someone that's not contending with diabetes?
So first of all, full disclosure, I am an advisor to Levels Health, and I'm also an advisor to several other companies that are working in the wearables for metabolic health space. So, I need to,
Sure.
fully disclose that. The goal is to get the insulin down. That's the goal. Okay. And I said that before any of these companies ever existed or before CGMs ever existed. All right. Get the insulin down. So how do you get the insulin down? Don't let it go up. So how do you keep it from going up? Well, you got to know what makes it go up. Well, a CGM, even in a non-diabetic, especially in a non-diabetic, will tell you what your glucose excursion is to a specific food. And from that, that's a general, indirect proxy of what your insulin response is to a certain food. And so if you know that there's a certain food that causes your glucose to sort of spike and go out of control, you ought to think about cutting back on that. Now, how are you going to get that information without a continuous glucose monitor? Now, do I think glucose is all that's necessary to predict metabolic health? No. But it's a good start. And it's here. I think ultimately we'll need other analytes to help us. I think ketones will be helpful. I think lactate will be helpful. Some people think glycerol will be helpful. I'm not sure. Alcohol might be helpful. The one that I think is the most important is insulin. And that's about 5 years away.
Right.
To keep it really granular for our listeners, if there were a couple of things that you would recommend that people would eat that would be healthy for their liver and their gut and their mitochondria.
Sorry.
Or and also maybe a couple of things to avoid, absolutely avoid. What would you say?
What would I say the things to avoid in terms of food? We're talking, right? All right. Well, so number one, soda. Number two, juice. All right. Liquid sugar is a bad idea. Period. End of story. 3 exclamation points. All right. After that, I think it depends on you. I think it depends on, the individual person. Things that are sort of hidden disasters are things like oatmeal, yogurt, breakfast cereal for sure. They've got sugar in them that you didn't even know they had. Pretty much any ultra processed food, and you have to be, wary when you go into the store. I mean, like for instance, you go into Trader Joe's and you buy their, frozen beef with broccoli. It's got 32 grams of sugar, but it's beef with broccoli. Yeah, but it's got 32 grams of sugar. Now, why is that 32 grams of sugar? I don't know, but there it is. The good news is that now they're putting added sugar on the side of the package. That's good. The problem is that it could not be added, but when you take the fiber out, it might as well be added. And this is the problem with juice. So it's not that they added sugar to the juice. Of course, some are fortified with extra sugar, and certainly all like Hawaiian Punch and stuff like that, way more. But when you take the fiber out of the food, you absorb the sugar so rapidly, it didn't matter that they didn't add it. Your body acts like it did. Okay, from a metabolic standpoint, they're indistinguishable. An orange juice and a Coke are indistinguishable. So fiber is the antidote to sugar. And the reason is because fiber does 6 things in the intestine, and they're all good. It does 6 really good things, but you need both soluble and insoluble fiber. And real fruit has both. Okay, so here are the things it does. Number one, it acts as a bulking agent. And so it will give you some gastric distension and thereby give you some mechanoreceptor stretch that will tell your brain, don't eat so much. The insoluble fiber, the cellulose, will act as a lattice work on the inside of the intestine. The soluble fiber, which are globular, will plug the holes in the lattice work. And so together they will form an impenetrable secondary barrier that will prevent early absorption of glucose, fructose, sucrose, simple starches, thus reducing the glucose excursion and reducing the liver's burden, thus protecting the liver. Third thing is if you're not absorbing it early, that means it's going further down the intestine, so the microbiome will chew it up. So even though you ate it, you didn't get it. So it's, in a sense, a caloric sink. Number four, the fiber will move the food through the intestine faster. So you will get the peptide YY satiety signal sooner. So you won't eat that second portion. Number five, the colonic bacteria will take that sugar that reaches it and will convert it to short-chain fatty acids, butyrate, propionate, acetate, which are anti-inflammatory and anti-insulin, thus contributing to metabolic health. And finally, number six, the fiber will act as little scrubbies on the inside of your colon and get rid of all and slough all the colon cancer cells. So real fruit does all of that. But juice only has the soluble fiber. You only get 2. If you ate cardboard, that's insoluble fiber. You'd only get 2. You need all 6. And you need the inhibition of the absorption the most, because that's the thing that's going to protect your liver and keep your insulin down. And you need both for that. So I think that processed food is the bad guy in this story, and have said so, because it's high sugar, low fiber. Conversely.
Absolutely. We go back to why it's so important that people are aware of how food can be medicine, because if we incorporate some of these strategies into our daily eating routine, our health, long-term health is going to be that much better.
Well, Deepti, I agree with you. Food can be medicine, but it can also be poison.
Which absolutely,
and people don't understand that. Okay, they don't understand that food can be medicine, but it can also be poison. They took this food as medicine thing a little too far, because it suggests that, it's about nutrition. Oh, so this has more vitamin C. It's supplemented with vitamin C, and vitamin C is so good for you, blah, 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 blah. Garbage. All right. So this is where, the rubber hits the road.
That's a great point.
We have to be clear about what we're talking about. Food is not always medicine. Sometimes it's poison.
Great point. Well, Bobby, do you have anything else to ask? Because I think there's so many more things we could talk about.
I don't. Rob, this was a fantastic talk with you, and I've learned so much from all of your experience and wisdom. So thank you.
That's my pleasure.
And Rob, we spend a lot of time talking about longevity topics and keeping in line with our theme of the monk and the hedonist. We always like to ask our guests, what is your guilty pleasure then, since we talked about fiber and no sugar? And
what's my guilty pleasure? And I will tell you, I don't get it very often. My guilty pleasure is Junior's cheesecake. When I go to New York, that's, the thing I can't avoid. I grew up in Brooklyn.
We all have
right.
something.
I had my very first piece of cheesecake at my graduation from junior high. Okay. And it obviously rang the nucleus accumbens a little too loud. And so whenever I'm in New York, that's kind of like my major guilty pleasure, with of course a pastrami sandwich beforehand. That's the other guilty pleasure.
New York is full of guilty pleasures. So yeah. Well, thank you so much. We really, really appreciated your time.
My pleasure. Thanks for having me.
Thank you.
Thank you.